You're listening to the Biohackers World podcast.
Hello, I'm Valerie Orsoni. I have been a biohacker since 1998, before the word was even coined, and my specialty is reversing the irreversible. That's why I'm very happy to talk to you today.
And I am David Karli. I am a regenerative medicine specialist, having researched and developed point-of-care biologic therapies since the early 2000s. And more recently relocating here to Florida, where we brought our biotech company, Greyledge Technologies, which I founded in 2010 to help facilitate research of these important products.
Great. So stem cells is a buzzword today in the world of biohacking, but not only biohacking. You see it everywhere, even in like regular beauty creams that claim they have stem cells in them. We have practitioners injecting stem cells from placenta, embryo, umbilical cords. Some people go outside of the US to get injections. Others take it in a form of the pill. Wow. And every time I talk to a specialist, he or she tells me the other one is wrong and vice versa. Can we please just have a few sentences and explain to us, first, for beginners, what's a stem cell? Second, where's the best form as of today? Would capsules work as well or not? And then we can have more questions.
That's a lot of questions to start with.
Because you're a smart guy, you just had a
unpack.
nice presentation. You know everything by heart already.
First, they're wrong and I'm right.
That's good. I like it. Me
I'm
too.
just kidding. I'm just kidding. No one has all the answers here, including me. But we're working to create a system that's going to get to some of them. And that's what I think is most important, is our contribution to the field to advance the science, because we don't know everything. What is a stem cell? Stem cell probably isn't the best term to use for cell therapies of this type, whether it's from bone marrow or fat or from a donor, which we'll talk about. Progenitor cell is probably a better term. A true stem cell is a cell that technically can become any other type of cell. Undifferentiated.
Yes.
So it can become bone, it can become skin, it can become brain, it can become liver, it can become heart, and it can self-replicate, meaning it can make more of itself theoretically indefinitely. Okay. Adult stem cells, the type that we use from a patient's own body, are probably better progenitor cells than stem cells because they can't make anything and they can't differentiate in an unlimited fashion. There's a limited amount of differentiation that can occur. So we tend to refer to bone marrow-derived stem cells as bone marrow progenitor cells or adipose fat-derived progenitor cells. Now, from a donor, and it's typically perinatal tissues or birthing tissue, which includes placenta, Wharton's jelly, umbilical cord, amniotic fluid. Basically, the byproducts of the birth are rich in progenitor cells, including true stem cells and what we call mesenchymal stem cells.
Yeah, that's another question I have.
MSCs. So MSCs are the type of stem cells which can help to address orthopedic tissue issues.
Knees, arthritis.
Knees, cartilage, tendon, ligament, also skin, mesenchymal tissues or mesenchymal lineage.
Hold on a minute. Wrinkles?
Well, wrinkles would be part of skin. So yes, mesenchymal stem cells in theory would be in that territory. As opposed to something, and I don't want to get too far into the weeds, but hematopoietic stem cells are the stem cells that make more blood cells. Those are the most prevalent in our body because our blood is constantly being recycled. Red blood cells recycled every 123 days, for example. So there are different types of stem cells, as we call them as the crow flies, but they are not all one type of cell. And that's what's important for people to know. It's not just throw stem cells at a problem. There's many types of stem cells and many types of differentiation of stem cells.
So in the US, not all types of stem cells are allowed. Am I correct on that?
That's correct.
Or it's been changing a little bit?
Yeah, and Florida is very unique there as of July of this year. So historically, the Food and Drug Administration puts out something called a Code of Federal Regulations. This is a 30,000-page document, but part of it covers HCTPs, human cell and tissue products, which stem cells fall into. That document historically said what physicians in the United States are allowed to do legally is take your cells, concentrate them, and immediately re-inject them without manipulating them or changing them in any way. And that's been that way. It still is that way to date. Any cell that was manipulated, cultured to make more cells, for example, even your own or someone else's cells, was considered a biological drug. Therefore, it had to go through a typical FDA approval process, which can take many years and hundreds of millions of dollars. In July, the state of Florida passed legislation which said, with a detailed informed consent, clinicians in Florida, physicians in Florida, could use an FDA unapproved product with the patient's consent. Now, there's things we have to counsel, like we don't fully know the risks and we don't fully understand the potential efficacy of the therapy, et cetera. That changed the game, but it was very interesting because it went against the Food and Drug Administration's position. So it creates an interesting legal conundrum.
Only 2 states, right?
Utah was the first, Florida is the second, but Florida is a much larger market than Utah, and we expect kind of the eyes of the world to be on Florida to watch how this experiment goes. So one of the things we felt that was important, we saw great opportunity there, but we also saw great responsibility to try to responsibly develop within those confines of the law to say, okay, we've got some new tools on the block. We still need to be scientific, academic, data-driven in terms of our approach towards expanding access to those tools and counseling patients fairly so they can make a good decision.
So we talked about data, which you are data-driven. I love data as well. Lots of BS, let's be straightforward, in the stem cell world. You see that and sometimes in the windows of medi-spa or even like beauty spas. Stem cell infusions, which you don't really know what it means. Today, what would you say is the big trap we should not fall into as either biohackers or people interested in stem cells? What should they avoid or pay attention to?
Yeah, it's a great question and a complex one. The patient consumer is in a tough position because if you do a Google search or a web search, so much information comes at you and everyone claims they're the best and they're a pioneer and they're world-class and they're this and they're that. We like to fall back on data because you can't really argue against well-collected data. So I can tell you we've treated thousands of patients, but if I haven't actually tracked those patients, it's purely anecdotal. Now, that doesn't mean nothing, but you can't fall back on a more detailed way to counsel a patient. Here's what you can expect and the likelihood of success. Because these are expensive procedures and patients invest thousands of dollars in them, we like to be able to handicap their success, so they can make a better decision whether they want to spend their money on this. No stem cell treatment in any doctor's hands is perfect. I have failures, plenty, and we learn from those failures in addition to the success. We want the home runs. Sometimes we'll take the double or the triple, right? A partial improvement might be a good outcome for some patients. We love, oh, doctor, you're the greatest thing ever, and that's awesome. And sometimes that happens, but sometimes it's, I'm better, but I'm not perfect. Then it's the question, are you good enough?
Do we do it again?
Or do we do it again, or whatever might be the case? Do we invest more money?
Yeah.
Right? So to answer your question, though, the educated consumer should be asking the doctor basic questions like, where are you sourcing your cells? How do I know they're safe? What's the quality control that went into those? Now, that's a buzzword, but basically, we want to know where they came from, were they processed safely and sterilely? Most importantly, I'm a huge stickler on, do they know how many cells? 99% of the procedures that have been done across the globe, the doctor actually didn't know how many cells were put into the patient.
They throw around billions. Yeah. Oh, 2 billions, 10 billions, 1 billion.
Right. But 20, 30% die if it's a donor cell model before they go into the patient. In the patient's own autologous model where it comes from their own body, it's probably like a 95 to 97% survival rate. So very, very good. So very few of those cells die. But when they're cryopreserved at minus 80 degrees and we thaw them and put them back into a patient, some of them die. Yeah. And we need to remeasure to understand our dose. We need to account for the ones that are dead because we can't assume that they're going to produce a positive effect. So how many cells are you going to put in me? Are you going to know that when they left the lab, or are you going to know that before they went into my body? Florida stem cell law says we have to do a post-thaw analysis. We need to unfreeze them, reanalyze them for both count and viability. How many are there and how many are there alive? Simple math tells us the number we actually put in that were alive. Then the question is, are they alive and will produce the effect in your body? Or some of my colleagues have argued they're in the process of dying but haven't died yet.
So how do we prove that?
Well, one way is to try to culture them. So you take cells, you take them from a umbilical cord or Wharton's jelly, and you culture them, and then you freeze them, and then you unfreeze them, and then you reculture them. Some of my colleagues have done experiments where they tried to do that and nothing grew on the second pass post-thaw. They were dying. So when they analyzed them immediately after the thaw, they were still alive, but they were in the process of dying.
Which means you would inject inefficient
we don't know.
cells.
So can dying stem cells still produce a positive therapeutic effect? So my colleagues in other states who don't have the luxury of being able to do this have been highly critical of the law to say, well, they're dying. Why would you put that in? But we hear anecdotal evidence from all of the offshore patients that are leaving the US to get these therapies in other countries. Some of them are getting better. So is that purely placebo? There's a lot of people that have done this. I think it's a little bit of a stretch to say it's purely placebo.
Speaking of offshore, I want to ask you a question.
Yeah.
A lot of biohackers get free treatments offshore. Mexico, Costa Rica, Bahamas. But all of them, 90 or 100% of them will say, oh, we had these flu-like symptoms a few weeks or month afterwards, which some of the American practitioners I've talked to said, no, if you use pure stem cells, it doesn't happen. What's your position on that?
We prepare for it with a donor cell model. So we give antihistamine medications. We give Tylenol for low-grade fevers. We used to think that umbilical cord or perinatal stem cells were invisible to the immune system. And animal testing has shown that that is not the case. The immune system does recognize them. The question is, are they alive for long enough before the immune system kills them, or they die themselves? That's a process called apoptosis to produce a positive therapeutic effect. And the answer is maybe. And that's what we have to study. So when my colleagues are critical, oh, they're in the process of dying, that doesn't mean they can't work. We need to test that.
But if you can't replicate or cultivate them, doesn't mean that they're not going to be active when you inject them?
You would think.
Yeah, I mean, yeah.
Then how are patients where that's happening in other countries?
Yeah.
Some of them are getting better.
That's true.
Right? We tend to, in the US, we tend to kind of dismiss other countries because they're not collecting data and they're not publishing, which they should. But you cannot deny a large body of evidence that some of those patients aren't getting better because people wouldn't keep coming back.
That's true.
If everybody who went there wasn't doing well, eventually the word would get out and no one would go back there. These places are thriving. They're packed. Now, they're very aggressive and you know, there's some critical thought probably to apply towards them and how they've handled this. I think it could have been done better. But what the Florida law does is give us a unique opportunity to try to do it right. And that is not to dismiss donor cells as ineffective, but to study them in a systematic way to say, well, are they alive? Do they produce a positive therapeutic effect? At what dose? Is it reproducible? And that only comes by studying patients over and over and over again, like we've done over the last 20 years when we use the patient's own stem cells. So I have that data set. What I need is the donor data set, and now I have a head-to-head comparison. Are baby cells better than mine? No one can answer that question because there's no comparative data.
Yet.
Let's get it.
Okay.
Then we can say, all right, do younger cells work better? I'm 70, I'm 80. My stem cells aren't any good anymore. Well, there's data to prove that they may not grow as well in culture, but when Philippe Ernegot is a Parisian, a French researcher who has shown that 60, 70, 80-year-olds have a very strong therapeutic effect to their own bone marrow-derived stem cells. So even though they're not as robust and we do lose them over time as we age, that doesn't mean they can't work. So I think one of the greatest opportunities with the Florida law is to take a critical academic data-driven approach. We have the data on using the patient's own. Let's get it for the donor and let's put them head-to-head and let's see who wins. Data. It's the only way I see to do it.
You mentioned bone marrow. It brings me to my next question. What's your opinion on capsules of specific supplements that claim they force the bone marrow to release about 50 million stem cells a day in your body, which in the end might be more efficient than just a one injection? Because instead of having one injection, which on that particular day, maybe your stem cells would be used for something else, to fix something else that you were not planning on fixing. Here they say, hey, you know, you get a small dose, but every day. What's your take on this?
There are medications that do that in patients who have very low blood counts, for example. We can stimulate mobilization of stem cells from our bone marrow, Neupogen and things of that nature. Those are pharmaceutical grade agents that are used in very specific applications, not for wellness or longevity or general health. So it is possible to mobilize pharmaceutically stem cells from the bone marrow to the periphery in the bloodstream. Supplementation is an unproven space. So is it impossible? No, it's not impossible. The data is weak. There's not a ton of it, but theoretically, it is possible. I think the metric we use for supplementation is their potential to cause more problems than we solve. If you look at Neupogen, when we mobilize stem cells from the bone marrow into the periphery in cancer medicine, for example, things like that, the white blood cell count never goes back down. There's a permanent increase, or at least a long-term increase. So there are repercussions to doing that. And that's why you don't do it for wellness or every day. So the question with a supplement is, if indeed these things are doing that, and I don't know that there's enough evidence to prove that they do, or if it has any positive therapeutic value, but is there any potential to cause harm? Because a supplement, over-the-counter supplement by and large, should be a low-risk thing to do. If you want to spend your money on it without a lot of evidence, as long as it's not going to hurt you, fine.
Yeah.
Right? Fine.
For sure. And then my last question, unless we have more time after that. Okay. As a woman, men as well, but I love preserving my face.
Yeah.
And not long ago, a company cryopreserved my stem cells and said, we're going to cultivate your stem cells, and then we'll create some sort of secretome that we can apply after we do some sort of deep scarring, like a microneedling, but a deep one. In your, I don't know if you've tried it or if you've looked at it, but in using what you know, is that something that makes sense and that should cause like some sort of improvement in the skin? Or is that something that's still yet not proven?
The answer is maybe, and it's a great path, I think, to research and study. The challenge, I call it the message in the bottle.
Yeah.
Can you control the message in the bottle to be consistent to direct the process that you want? Cells communicate with exosomes. Secretome is a type of exosome. It's what's released by the cell to produce its effect. There are millions of types of exosomes, some of which are good, some of which are bad, some of which signal cancer cells to grow, some of which signal bad things like pro-inflammatory. So if you look at an exosome, which is similar to a secretome, there's hundreds of biologically active materials and mRNA and all kinds of stuff in there. It's very complex. Do we have, and when I meet with exosome scientists, I ask them the same question. Do you have consistent control of the message in the bottle? Because when I put a living cell in, it reacts to its environment naturally. That's what it does. When we cultivate that in a laboratory setting, it's not the same as what's happening in the body. So we try to simulate similar conditions to produce the message in the bottle that we want. But the scientists that I've met with have said there's still variability in controlling that message. So I think my criticism and the limitation in exosomal medicine or secretomal medicine, as you describe it, is, do we have quality control over that message in the bottle to consistently produce a predictable effect? And the answer is no, not yet, but the potential for that is there. So I was meeting with a gentleman who was describing that for hair, where they actually take a hair stem cell and they take the secretome and they reapply it back to hair. Well, that does make sense, as opposed to taking a bone marrow stem cell and trying to do the same thing. So there's merit to the concept. Everyone wants youthful skin.
Of course.
Myself included. I would love some more hair.
So do you want me to inject stem cells?
Are they going to hurt me?
No.
How many are there?
I'll give you 1 billion.
Do you know what the message in the bottle is?
We'll discover it together.
Do you know the predictability? What's my likelihood of success? These are the questions that patients need to ask. And sometimes the answer is, by the way, and it's okay
to not know.
We don't know.
Yeah.
So when I counsel patients, here's what we know from research, here's what we know anecdotally, and here's what we don't know. It's okay to say we don't know. That's not going to reduce a patient's confidence in you. In fact, we've found they appreciate the honesty.
For sure. They don't like if you're like a car salesman. Yeah.
Right. So what we're seeing and where there's criticism to be made is of the people that are making false truth claims and promising things that are unsubstantiated anecdotally or, more importantly, by data. That's no good. Right? We need to educate patients to make a good decision. If we do so effectively, they can. The best compliment I've ever gotten as a stem cell medicine guy is a patient who didn't get a positive response to their therapy, but referred 10 more people to see me.
Oh, that's good.
That's the best
compliment. I hope you treated him for free after that.
Well, look, it happens. Not every single patient responds. And every patient I see hears the words, it is possible this will not work for your problem. It's possible. Here are the odds based on what we know. Sometimes we don't get an effect, but if patients felt that they were treated fairly and well and we took good care of them, they'll feel confident that even though it's unfortunate, we wasted some money. We didn't buy the outcome we had hoped to get. They still thought enough to send someone, a relative or a family member to me. That's the best compliment I can get.
I agree. Well, thank you very much. I think we've reached our 20 minutes.
It's great talking with you.
I'm already looking forward to the next events in 2026. Los Angeles and to Chicago and to New York. And I know in January after there's going to be Miami as well.